Great. Next we'll have Shannon McDonald from Loyola University presenting healthcare disparities involved in establishing functional hemodialysis vascular access.
Thank you for inviting me to present today. My name is Shannon. I'm a third-year medical student at Loyola, and we have no disclosures. Disparities in healthcare among racial groups in vascular surgery care is well documented and continues to be investigated. Fistulas are the preferred method of access for dialysis patients. Ideally, patients will achieve fistula or graft maturity prior to the need for dialysis in order to limit the use of a catheter. However, in many patients, it takes multiple procedures in order to achieve and maintain fistula and graft maturity. And in some cases, fistulas may fail to mature at all, in which case new AV creation is necessary. Previous research has shown that AV fistulas have a primary failure rate of 30 to 70% and a 1-year patency rate of 40 to 70%. We suspected that racial backgrounds may influence a patient's risk for requiring additional fistula or graft surgeries in order to reach AV access maturity. Our study is a retrospective cohort study. We identified 926 patients undergoing first-time AV access at our facility between 2007 and 2021. Subsequent AV creations and maintenance procedures were captured and totaled for each patient. Maintenance procedures included fistulograms with percutaneous intervention, collateral vein ligation, thrombectomies, and any revisions needed. Patients were then categorized by racial demographic and number of additional interventions. This table here demonstrates the demographics of our study. 45% of patients identified as white and 37% of patients identified as Black. Here we're looking at the frequencies that comorbidities appeared in each racial group. As you can see highlighted, hypertension, COPD, diabetes, and anemia are all higher in the Black population as compared to their counterparts of other races. Here we are looking at the total additional AV access, maintenance, and creation procedures after the initial fistula or graft is placed. 53% of patients required no additional procedures. 28% of patients had no additional procedures at our facility. 10% of patients required 2 additional procedures, and 9% of patients required 3 or more procedures. Here we're looking at the association of patient race with AV maintenance surgical interventions. Given that we have count data, we did a Poisson regression. White race was used as the reference group, as that is our greatest number of patients, and in order to create contrast estimates. So Black patients have a 0.6 times higher count of having additional AV maintenance surgical interventions as compared to their white counterparts. And the patients in the other group have a 0.5 times higher count of having additional AV maintenance procedures. Similarly, here we're looking at additional AV creation procedures, and you can see that Black patients have a 0.3 times higher count of having additional AV creation procedures as compared to their white counterparts. Here we are looking at the association between patient race and additional AV creation and maintenance procedures. So we broke patients down into groups based on if they had no additional procedures at our facility, 1 additional procedure, 2 additional procedures, and 3 or more additional procedures. As you can see highlighted, Black patients have a 1.8 times higher risk of having 2 additional procedures. And Black patients also have a 2.9 times higher risk of having 3 or more additional procedures. So in conclusion, Black patients had a higher frequency of hypertension, COPD, diabetes, and anemia. Just over half of our patients required only the initial fistula or graft placement. Black patients were at a significantly higher risk of having additional AV access surgical procedures, including both maintenance and new creations, as compared to their counterparts of other races. Further exploration of these disparities is necessary in order to discover the root of the inequities in care, as the causative nature of these factors has not yet been determined. One of the major limitations of our study is we only have data from our institution. So if patients receive their initial fistula graft at our institution, they could have followed up elsewhere for their maintenance procedures. Additionally, patients who underwent access later in our study, such as patients in 2021, might not have outcomes fully documented yet. As you can see, hypertension, COPD, diabetes, and anemia are higher in our Black patients, and that could all contribute to factors or reasons why Black patients required additional procedures. Additionally, as we know, race is often associated with lower socioeconomic status, and lower socioeconomic status influences the patient's utilization of healthcare and can lead to poorer outcomes and worse managed chronic conditions. Some reasons why patients may only have one procedure at our institution could be that a patient received a kidney transplant, a patient could have chosen to continue to dialyze through a catheter instead of undergoing another procedure, and in these patients there's a high enough mortality and morbidity in these end-stage renal disease patients that may limit them from undergoing additional procedures. Thank you, and I'll take any questions.
Great presentation. One question I had, were you able to look at your different subsets and see how many of them were initiates with a dialysis catheter before they got access creation?
So we didn't look at that, but that'd be something great to look at going forward. And we also want to separate out what type of access patients had, and where their access was, to separate out fistulas and grafts within each cohort. Thank you.
Good morning, Greg Weston from Indianapolis. Thank you for this talk. I think it's very important that we were thinking about disparities in all of the areas that we study. And one comment I have is that while of course it's important for all of us, to your last point on your conclusion slide, I think it's important in all of our studies to distinguish between correlation and causation, but this is an area where we often, all of us, tend to assume causation with regard to biologic effect, when in fact this may very well be the result of a social or economic effect. And so one way that might have an impact, I wonder if you think that there might be a change in these results with the coming change to calculation of GFR with regard to race. Are these patients essentially seeing the effect of being referred too late for dialysis access because their GFR has been miscalculated and they've been assumed to have more mild disease than they actually do?
That's a very good point and would be great to look at going forward, and I think that's something we could look into. Thank you.